Good morning, everyone. It's very kind of you to invite me to represent the Ocular Oncology service from Liverpool here. I'd like to introduce myself. My name's Heinrich Heimann, and as you've guessed, I'm not from Liverpool originally. I come from Germany, and just as a bit of background, I had my training in Berlin with Professor Förster and Professor Bornfeld. They are the two leading ocular oncologists in Germany over the past 30 years, and they established the two centers in Germany, which are Berlin and Essen. I then went to Liverpool about 8 years ago, and mainly because I was attracted by two consultants there, Professor David Wong and Professor Bertold Amato, who you all know. These are really two absolutely world leaders in their field and world famous for what they've been doing, and I thought it would be great to work together with them in Liverpool. Unfortunately, both left now. I don't know what I've done wrong, but Professor Wong went to Hong Kong, set up the university there, and Professor D'Amato is now in San Francisco setting up a new oncology service there. So that leaves our little team, and we've got 3 members here. I'm very glad that they came with us, Sam and Jill and Dawn, in the ocular oncology service in Liverpool, and we hope we can sort of steer the ship to further horizons and improve the treatment of ocular melanoma in the future. It's a bit strange talking in front of a patient forum. I have to say, it's my first time, and I was a bit nervous really about it, so I felt like this little one in the middle there. So I hope you don't mind if you just look after me. I showed this slide in South Africa, actually, because everybody's asking me, what happened to that? They never ask me about the scientific part of my talk, but what happened to the little one there? And they couldn't answer me in South Africa, but they said, no antelope in South Africa dies of old age. That's all they could comment on. So that will probably be the outcome of that. But as a starting point, we have to work together, is to ask you what you feel is the most important part about the treatment. And we've done that in Liverpool, and I'm very glad that Laura Hope-Stone can give us the data. So we asked all the patients after their treatment's finished, what's your major concern? And if you look at it from an ocular oncologist point of view, we are eye doctors, we haven't got much to do with it. It's a lot more important what the 2 speakers after me will tell you. The major concern is the prognostic biopsy result and the cancer spread. So if you're still concerned about, there is some discussion within centers, should you do a biopsy, should you look at prognostication? These are your 2 major concerns of the patients we have. So there's no doubt that this is very, very important. And if we look at eye doctors, we really come down the ladder somewhere there. Work and driving are the first ones where we come in, where we make a difference. We can't really make a big difference, just little difference, but not a big difference to the general disease of it. But we can do something for the eye. Work and driving, and later on, vision here, what we think obviously as eye doctors is so important, comes really on number 10 or so of it. So we really have to change our focus. And I'm discussing beforehand as well, patient focus group and patient interest group are getting so important nowadays. So if you go for grant applications, really the question is, what do the patients think, for all the right reasons? So we shouldn't do what we've done in the past, to research for ivory tower for ourselves, but we have to get involved with you, and you have to tell us what to do. And if you're an OcuMel, really, if you're representatives of the patients with ocular cancer, that's a very strong position for you in the future, because you really call the shots, believe it or not, on big grants in the future, I'm pretty sure. So it is very important for both sides, for us to know what the direction should be, and for you to raise your voice, to really get together and, as a representative of that group, tell us, we're really concerned about ABC and not so much what you think DE. So honestly, the most time I spent on here obviously is not what you're concerned about. So we have to change it, and we try to change it in Liverpool as well for the future. Just like to give you a brief overview of the services you have in the UK. It's quite interesting because I come from a completely different system, from Germany into the British system, and I'm pretty sure now that some of you would have not so good experiences in the NHS with your treatment, perhaps some delays or some real problems, and you're not happy. Looking at it from the outside, I think I have to say it's an excellent service. There are not many services like this, I have to say, worldwide. Why? Because it's a rare disease, it's a dangerous disease, but it's focused in 4 centers. You have 4 centers where you have to be treated, whereas in Germany you have about 20 centers or so. German philosophy is completely different. It's a pyramid system, and if you're in a hospital somewhere, let's say in Leicester in Germany, you would never ever refer a patient somewhere else, because it's a sign of weakness if you do that. So you try to treat it yourself. So in Germany would have 15 or 20 centers, each treating about 20, 30 patients a year, and compare that to a center here which treats between 100 and 300. It's not that we're more clever, but you get the experience of treating more patients. You see more complications. You know what to do and what not to do. And I think that's absolutely an excellent service here that you have to be channeled in. And also the cooperation with the ophthalmologists in other hospitals here is much, much better. In Germany, you wouldn't be able to treat somebody and then refer them back to the hospital for the aftercare. Nobody would take over the responsibility. Whereas here, we have very good cooperations with most of the people in the country to really take and share. If you're coming from the South Coast to us for treatment, you can't come every 3 months for the next 5 years. It's impossible. So we do need our colleagues closer to you that really can take over the post-operative care, and have to say that cooperation works much better than what I've experienced before. So although I'm pretty sure that quite a few of you would have had bad experiences, I have to say I think the service in general is very well organized and very well funded. You don't have any issues about treatment too expensive or so. You get the best treatment in inverted commas that's available at the moment within the NHS, and you don't have to go privately or whatever for it. So just looking at our center over the past years, 2007 to 2011, these are the referrals and the patients with a diagnosis of a melanoma. Last year we just went over the 300 patient mark, so we see about 300 patients with choroidal or ocular melanoma a year in Liverpool. Where do they come from? Most of them come from England. We do have some from Wales as well. Ireland's got Neil Horgan, got an ocular oncologist, and you can see that he's now treating most of them, which is very good. I'm not sure whether you're in touch with the patients from Ireland, but we do see some for proton beam radiotherapy, but they're mostly now treated locally, which is a very good development. We do have overseas referrals as well. So looking at the choroid itself, this is the movie we usually show to explain the tumor from the outside. Zooming in at the back of the eye, we do have the retina, and it's quite important. And if I explain the treatment methods and the differences, to look at 3 different things. Really, this is the retina, as you know, the part of the eye that can see. But really important for vision is only this little part here. So it's always underestimated. The retina goes up to here, but this part looks at your nose, and so it's blind, really. So what's really happening is only here. Only here you're able to read, only here you're able to recognize faces, and only here you can do your work. And this is the optic nerve head. That's the connection to the, from the eye to the brain and your umbilical cord, basically. And these are the 2 most important structures if we think about treatment of the melanoma. The choroid is under the retina. The retina itself is like cling film. It's transparent. It's, you can look through it. So the retina really comes from the choroid. It's the it's most blood, all the blood supply to the eye is in there, and it's a lot of blood supply. It's really per square centimeter or millimeter, the best blood supply in the whole body. So eye doctors usually don't like the choroid because whenever you touch it, boom, it's going to start bleeding. So during surgery, and this is why the surgery and the treatment of choroidal diseases is quite difficult. And a choroidal melanoma, you can see here, it's bulging forward under the retina. The retina is pushed forward, and it's starting in the melanocytes in the choroid itself. Now, there are different parts of the choroid. Where can we find the tumors? Most of them in the choroid itself, at the back of the eye, about 5 to 10% in the ciliary body. The ciliary body is part of the choroid, and that's the waterworks of the eye, where the water is produced that keeps the shape of the eye. It's a bit of a dangerous area as well. These tumors in the ciliary body region are dangerous for 2 reasons. Number 1, this is the hidden corner of the eye. If you remember, the retina here looks there, so it doesn't see anything. Only this part of the retina really can see to the outside. So if anything's growing here, you have no idea. You don't notice it. So it has to grow until it's in the visual axis before you can see anything. Or on the outside, you see a big blood vessel popping up there and inflammation. So they have to grow into a substantial size before they're diagnosed in the first place. And second, there's a very good blood supply there. So tumors in this area are more difficult to treat and are usually associated with a higher rate of metastasis as well. We do have few tumors in the iris, and the iris is part of the choroid as well. So it is choroidal melanoma, but they're only 3 to 5%. They usually have a better prognosis because there's not so much blood supply in there. And very rarely we do have tumors in the retina in adults, but most of the tumors we see are in the choroid because the retina is nerve cells, so they don't divide after you're born. So there are not many cells there that can turn into malignant tumors. It's only the children, the retinoblastoma, that can get these tumors. So about 1/3 of patients do get the tumors at the posterior pole, and these are the symptomatic tumors. So what symptoms do you have? Well, it has influence on your vision. You usually see light flashings. You see metamorphopsia, that means straight lines aren't straight, a bit wavy, and you have visual loss. You have blurry vision. But these are all unspecific. So if you go to any optician or any eye doctor with these symptoms, they wouldn't think of a melanoma. They think of something else because melanoma is so rare, so they're unspecific, really, symptoms of that disease. Briefly now to the tumors itself. An iris melanoma you usually see as a growing spot on your iris. We do the anterior segment ultrasound. They're fortunately rarer, and they're usually smaller and have a better prognosis. So the standard treatment nowadays in our unit is proton beam radiotherapy, where you can treat most of them successfully. We do have some recurrences, but not many, because you can see the tumor. It's easily visible for the radiotherapy as well, and you go straight forward with the treatment. So what do we do with posterior melanomas? And do we focus on vision too much? It may be that we also do have an influence on prognosis in metastatic disease. And that influence could be in small tumors. So it could be, and the statistics really pointed to that direction, this is a very small melanoma that was very aggressive and grew rapidly, really over a short period of time. It could be that we treat these ones successfully. We as eye doctors can have a benefit for the patient regarding metastatic disease, because we think that a lot of them start off as low-risk tumors, i.e. disomy 3 tumors, but if they grow to that size, that somewhere there's a switch in there and they change to monosomy 3. So if you don't treat it appropriately, if you have a high rate of recurrence, if you don't treat it at all, we put the patient at risk, because it may be that in this situation there's no risk for metastasis. In this situation there's a high risk for metastasis. So although we can't do much, to be honest, our metastasis rate is comparable to the first one ever published by Fuchs in Vienna at the beginning of the last century. The success or survival rates were pretty similar to what we have now, which is not good, really. It's nothing to be proud of in inverted commas, but that gives us the spur to really research, and the 2 next speakers really working on that much more than we do. But we can go one step before that. We can try to treat the small melanomas early in order to prevent metastasis and treat them successfully, and hopefully with good vision as well at the same time. So where can we really start to identify them earlier? And this is a study that's been done by Bertel D'Amato together with Erika D'Amato. When you come to our unit, you get a questionnaire asking you what happened, really. When did you first notice something, and what went on from there? So really looked at all these questionnaires, and the outcome was, in a nutshell, 30% of all tumors are asymptomatic. So it's a malignant tumor that is asymptomatic in 1 out of 3, which is quite amazing. It's picked up by routine examination going to the optician, really. They saw a spot, and 1/3 of them didn't have any symptoms. And more, this is not a finger-pointing exercise. This is just really to find out where can we improve, where we can pick up these melanomas earlier, to treat them earlier, to have better visual outcome, but also have a better prognosis in the future. But 21% of tumors were initially missed. The patient went with unspecific symptoms or whatever to an optician for a routine examination. The tumor was judged to be in a position where it should have been visible, or should have been, the next examination should have been done then, but it was initially missed and there was a delay in there. And in 1 out of 10, 11%, we had a delay of more than 6 months before the patient went to professional optician or to an ophthalmologist with symptoms, or either a lesion has been seen and before the treatment was started. So clearly, as I said, it's not a finger-pointing exercise, but this is where we can really move things and can get better about it. So if you, as a patient group, obviously what you want to do is raise awareness about it. So would it make sense to put posters up with little pigmented choroidal lesions, yes or no? These are all directions where one can go, but clearly in this area there is room for improvement. And there's room for improvement with communication with the opticians. I think the communication between eye doctors and opticians is very, very good in this country. In Germany, they don't even talk to each other because one is fighting for the patient and others as well. So it's very good that nowadays there's more communication here. And you may know that more and more opticians do have cameras and look at the back of the eye a lot more than they used to. And this is your first point of contact, really. So in this area, I think we really have to improve to get this collaboration together to really raise the awareness and what to do with these lesions then afterwards when you pick them up. So I think this is really an area where we can improve the treatment and the prognosis for quite a number of patients. Because here you see just 4 picked out lesions that look pretty much similar. So small pigmented or non-pigmented lesions at the choroid, at the posterior pole. And we're sort of a funny species because we usually make the diagnosis of cancer without a biopsy, just based on clinical grounds. That's not very many cases where you can do that, but we can do it. Why? Because about 30, 40 years ago, no questions asked, such an eye would have been enucleated, okay? Just removed because it could be a melanoma and we don't want to risk anything. And then you could look under the microscope what was the diagnosis before and what came out of it. And it turned out to be that in specialized centers, the accuracy is about 97%. So if you're in a specialized center on clinical grounds, you can make the diagnosis in 97% just based on these examinations. You don't need a biopsy to verify the diagnosis. There are a few exceptions, but this is why we, in one way or another, think we know what we do, and we're getting the feedback now from the biopsies as well. So what could it be? Just, this is a nevus, this is a melanoma, and this is something else. It's actually hemangioma, looking like a melanoma sometimes, but every week we do have a lesion, we don't know what it is in our service. So every week we have to say, this is an indeterminate, and we have to take it from there then. So we are not in the know and in the 100% knowledge in all patients, though there still is a group, and we have to get better at them as well, because what do? You wait for growth, really. So some lesions grow, some don't, and it may be that the ones that grow, and takes a long time to grow, 6 months or a year, you may be putting the patient at risk. So it would be much better if we could get rid of the indeterminate lesion in the beginning and know exactly what it is. We're working on it, but we are not quite there yet. Because, and this is what you have to know, it's a very common thing to have a little brown spot at the back of the eye. These are all the studies, and the one that comes closest to our population here would be one from Australia with a white Anglo-Saxon population there, and it's in the region of 5 to 6%. So if you take everybody from the high street and take them to an optician and really give them a good examination, 5% have a little spot at the back of the eye. That's a massive number. Just sort of so you know about it, it's the patients with diabetes is about 5% of the whole population. So it's pretty clear that our little team cannot look after 5% of the population and screen them every 6 months to see whether they're growing, yes or no. So at the moment, in inverted commas, we are just lucky that they've not been picked up. Otherwise, they would really swamp our hospitals and we wouldn't be able to breathe anymore. But for the future, if we take the next step to the opticians and to screening and to cameras, we have to think about this 5% and we have to channel them somehow that we can look after them in an appropriate way in the future. So this study from Australia also looked at changes, and they looked at more than 100, and only one of them changed in over 5 years. So of 160 spots they looked at, only one changed this tiny bit. And you can see it, it's really on these pictures, you can't really make it out. So most of them never change, and this makes it so awfully difficult. Most of them you see are harmless, absolutely nothing. And the big question is, how do you identify the one that will then turn into a melanoma in the future? And do you really have to expose all the over hundreds of patients or thousands to 6 monthly screening follow-up examinations where the risk is very, very low? And that's a difficult question, and I don't have the answer yet. We have to work on it in the future, and at the moment the best thing we can do is go by risk factors. There's an absolute standard publication from the group from Shields in Philadelphia looking at risk factors. So that's what we do with every small melanocytic lesion. We go through the number of risk factors. Is it touching the disc? Is it more than 2 millimeters thick on ultrasound? Does the patient have symptoms? Is there fluid associated with it, or orange pigment? The more risk factors you have, the higher the risk for developing a melanoma. And that's what we do in our clinic. So this is how we come and define this by risk factors, really, but we're still left with that group of indeterminate lesions. Now, how do we look at them? The basics are really the same. They haven't changed over the last 150 years, or the only addition would be ultrasound. So we look at them with ophthalmoscopy and photo documentation. That's the most important thing for the follow-up. So if you do have a small spot, the most important thing is get a photograph of it for future reference, really. Because if you go by the old drawings and things like that, they're not as precise as a photograph. It's really most important that you have photo documentation. We look at them then, compare it to the photo documentation, and we do the ultrasound. The ultrasound is very good for melanomas, but it's not really good for small lesions. Why? The resolution is not good enough. And that causes a lot of confusion, and I'm sure a lot of you have been affected by that confusion. If you measure this small lesion today, you can't hardly see it here. And you go to a different hospital, different machine, different examiner, you will have different measurements. And then there's a panic. It's 1 millimeter more than it was in the other hospital, and vice versa. It is not precise in these lesions. So this is why when we're looking at these small lesions, we don't go by the ultrasound, we go by the clinical picture and the photo documentation. So that's very important, and something that we really have to improve in the future is that ultrasound is, because you measure, you think it's an objective thing. No, it's a subjective measurement, because the examiner puts the things there. It's not an objective measurement, and that's a really big problem in daily life. So what has been developed over the recent years, and really big addition to our clinic, are two things: autofluorescence. This is an examination method that's in the new imaging machines that we have in our clinics, and that looks at orange pigment. So if you have orange pigment, clinically it's hard to detect, but with the autofluorescence you can see it a lot better now. So this will give you one risk factor, yes or no. And we do have the OCT scans. The OCT scan is like a slice of cake through the retina, and it can show you fluid as well. So in recent years, we got better at detecting orange pigment and detecting retinal fluid, which are two of the main risk factors for malignant transformation.
So, what is the orange pigment chemically?
Orange pigment is lipofuscin. It's just a coloring agent in inverted commas that we don't know why it's a risk factor for melanoma, but definitely in nevus going into melanoma, this is one of the things we look at. So if a patient comes to clinic just like that, what do? We do an ultrasound as standard. Also, sometimes you can only see the tip of the iceberg, so the ultrasound is important to see that there's nothing bulging at the back of the eye. So we still measure them, but it's not as precise. We do an OCT scan, and you can see here that at the side you can see some fluid there. So it's very, very sensitive to detect some fluid. And we do autofluorescence that picks up the orange pigment over the lesion. So that patient has two risk factors, but are two risk factors translating into a melanoma? Not yet. So we have to say it's an indeterminate lesion. So we don't know. It could be a large nevus. It could be a small melanoma. So what do? Well, you can debate it very long and hard. So this patient is asymptomatic, but you can see that the lesion involves the fovea, so your point of best vision. So if you say, we got two risk factors, it could be a melanoma, I want to stay on the safe side, I treat it like a melanoma, you have to treat the fovea as well. So with that decision, what you're doing is you will kill all vision straight away for something that may not be a melanoma. So you can see how difficult that decision is. You don't really want to do that. You need a bit more evidence. But you can argue another way. You can say if it really is a melanoma that is starting to develop, if we wait for it to grow, we may increase the risk for the patient getting metastasis. So that's a real problem as well. So that's a catch-22 situation here. And what do? We explain all the options to the patient and then take it from there. There's no right or wrong. And unfortunately, in inverted commas, a lot of patients don't like it, but it's your choice. It's patient's choice. I don't know what's right or what's wrong in this lesion. We have to discuss it, and then it's your choice. And the choice would be either to observe it or to go for a biopsy, try a biopsy, which is tricky in small lesions to find out what it is, or treat it straight away. And this is what we discuss with every patient in these lesions. If we observe, we go for 4 months, 6 months, 12 months, 24 months. And this has changed completely in our unit because of the development of the new imaging methods. We've got a wide-angle photograph machine now, the Optus machine, which is absolutely brilliant. So we do have a wide-angle picture where the whole lesion is on there. And these are two. And you can see for yourself, do you think they've changed, yes or no? It would be awfully difficult just having a sort of a drawing of this and looking into that eye 6 months later. It's awfully difficult if you have normal fundus photographs because they don't give you the whole view, just a part of the lesion. And then looking inside the eye and looking at the photograph is very, very difficult. And now with these new machines, these are two growing lesions. Okay? These new machines make it really a lot easier. And this is the Optos. You can see that this is sort of baseline, and 4 months later you can have a high magnification. You go around there and you can really screen around there. And this is what Jill and Sam are now doing in our clinic. So we have a nurse follow-up clinic for these lesions that have a risk factor. And you can see that in some parts they are changing. And I'm pretty sure that we pick up a lot of changes a lot earlier with these new camera systems, which is brilliant, that we couldn't do before. And this is how we follow up the patients and have a lot higher rate and detect it a lot earlier. But there's still some that, for instance, this patient, fluid on OCT, orange pigment as well. You think it's a melanoma, but the next information is that's the only eye of the patient. He lost the other eye through an injury. So you think on clinical grounds that's probably a melanoma, but we decided, we can't really treat it because this is in the worst possible position. The patient will be blind afterwards, so we just wait and see. And sometimes you will have a surprise. So this is the patient then after 7 months, and it hasn't changed at all. And now got 1.5 years, it hasn't changed at all. So probably this is a large nevus with fluid and not a melanoma. So I hope I can show you how tricky it is sometimes in these lesions. So what do we do? The next one, what we can offer is a biopsy in these. So I come to the biopsy now. And this has changed our approach completely over the past years. These are our new patient, and this is about 300 now. And we do a biopsy in about a third of these patients. You have to know that about a third of them will be enucleated, unfortunately, still. So we do have a biopsy material in inverted commas in any way. So about 2/3 of all patients that we do not enucleate, we do perform a biopsy. And the reasons for biopsies are the small lesions to find out the diagnosis, if you have a metastasis to find out the primary tumor, if you have lymphoproliferative disease, and sometimes we have lesions we really don't know what it is, we go for a biopsy. And that has an impact on treatment as well. So to me, there's absolutely no doubt that it will be there for the future, because this is a melanoma. Okay, we know about it, but for prognostication purposes, if you don't do a biopsy, you have to go by general risk factors. You go there and there. But if you know it's a disomy 3 tumor, the prognosis is much better. You know if it's a monosomy 3 tumor, then the prognosis is much worse. So that has an impact straight. Should I send the patient to Southampton straight away, or can he just be monitored locally? But it also has an impact on the treatment of the eye, because obviously if it's a monosomy 3 tumor, you probably want to put more emphasis on treating everything with safety, whereas if you have a disomy 3 tumor, you may think I put a more emphasis on the vision outcome than on the general outcome. And this is how we do the biopsies nowadays. It's just with a cutter. We're going really into the tumor and cut away a piece of the tumor to then go for the biopsy and get the result. And this is what you get. You get 2 outcomes of the biopsy. You get the histology that tells you melanoma, yes or no. But the second step, what we do with these lesions afterwards, we also do the gene profiling on that, the prognostication of the lesion. And this is quite important. But you saw already that you don't get big chunks out of it. There's a lesion before and after biopsy. This is really all you get. And if we really look at it critically again at our roles of it, what I do as an eye doctor really is, this on the CSI, just pick up the pieces and try to forward it to somebody who makes the diagnosis. So that's worth absolutely nothing if you don't have the person at the other end who makes the diagnosis. And if I go back, making the diagnosis of cancer on this, of the eye, with a massive impact is too much for a routine pathologist, okay? They might not even see it because it's difficult to just preserve this little piece of tissue. So you have to be really specialized on that. So that's very important. It's no good running into biopsy if you don't have the backup of a good lab behind you. So these people are very important for us. They're so important that I married this person, actually. I always have her with her. This is Sarah. I think she's been here last year and giving you a talk. She's got a different name, which when we married, almost we didn't marry because of that. But now it's very useful because with different names and publications, and doesn't look like she just puts her husband on the paper just for free. So it's a very good decision, but this makes a bit of a confusion sometimes. So we established the service, or Sarah established the service, and these are all professionals, technicians and doctors and PhD students who all do ocular melanoma all day in and day out. So there's a whole team really of people looking at all aspects of the melanoma, and we sort of trying to improve it, the biopsy techniques in the future to give you a bit more better prognostication for the future. I just have to, I think, skip a bit and come finally to the treatment really of it, which would be of more interest to you. Sorry for that. Okay, what do we do now? Now for the treatment. Just a brief overview of our treatment methods. It is 1/3, 1/3, 1/3, and the extras. Our stalemate treatment still is brachytherapy of ruthenium plaque radiotherapy. We do have the facility of proton beam radiotherapy, and unfortunately, we still do enucleate about 1/3 of all eyes because the tumors are just too large or around the optic disc on diagnosis. So if you look at the treatment over time, it's pretty much the same. What we want to achieve in the future, obviously, is to reduce the number of enucleations. But we're not there yet. We're only getting it slightly less, but not really much less compared to what we've done in recent years. Just to give you a very short overview of our favorite treatments, our favorite treatment really is the ruthenium plaque radiotherapy. And this has been developed by Professor Lommatsch in Leipzig in East Germany. It's one of the very few good things coming out of East Germany, and it really made an impact. But because it's from East Germany, it's only available in Europe. If you, I don't know, as a patient, look at all the publications from the US, they don't have ruthenium plaques. They all do iodine plaques for two reasons. Number one, indeed, is it came from communistic Germany, so it couldn't be any good. Number two, the first plaques, unfortunately, they had a lot of nickel in them. So patients, the first patients had massive allergic reactions, some of them, around the eye. So when the Americans did the first ones, they said, oh my God, what is this? This is no good. And it's got a bad name from there on. And it's just never been. And they're just trying to get the FDA approval again. And we think it's completely wrong in our hands, and everybody in Europe would agree. It's the best treatment we have for a standard normal melanoma because we know exactly what we're doing. Why is it so popular? Because you can see the treatment effect about 3 to 4 months later. So you do have the melanoma beforehand, and after treatment, you can see the scar, and you know exactly the footprint of the plaque you put on, so you know exactly what you're doing. So you can, wherever you position the plaque, you know where you've been, and after 3 to 4 months, you have assurance where you are. And this is quite unique to the plaque radiotherapy, and this is why it is so popular in most centers. The other alternative for radiotherapy we have is the proton beam radiotherapy, which is heavy ion treatment, a type of radiotherapy. And the good thing about it is you can have a sharp margin between treated and non-treated area. That's the advantage of it. So this is why we use it. And the only centre in the UK where you can treat eye patients is in Clatterbridge, which is half an hour from Liverpool, which is great for us. There are other centres, and there are more coming up. But the problem is it's sold as a VIP radiotherapy. So there's a lot of private investment in it, but you can't just treat people like that with proton beam radiotherapy. You have to have a special annex to the whole treatment thing. It's very, very expensive. So I don't think in the future there will be other sites. And actually in Germany, they have 2 sites building up, not a single patient treated because it's so expensive to keep it running that they're just really ruins at the moment there and not running. So the big hype about proton beam radiotherapy seems to be wearing off in a lot of centers. Now, we do have our facilities in Clatterbridge out in the paddocks. It's a really nice setup, the special eye treatment there. And this is how you get this high precision radiotherapy. You have to face mark like an ice hockey goalie really to really precisely put the radio beam into your eye. You need one surgery beforehand with tantalum clips where we just outline the tumor. So you put the little markers, this is the tumor, put the little markers like a baseball field around it, so it's visible then in the field of radiation. So on X-rays you can see the markers, and that then gives you the precise field of radiotherapy. And it's very useful really for tumors at the posterior pole of the eye because you can put a sharp margin on it. The problem about it you see here as well. This is 2 years after the treatment, and there's not much of a reaction you can see. The only effect you can see is the tumor is not getting bigger. And that makes the follow-up so much harder really in daily life. So with ruthenium plaque, after 6 months, you know where you are. It's black or white. After proton beam radiotherapy, you don't know what's happening really. All you know, it's not getting bigger, and you hope this is the sign of not extending further. Fortunately, it's a very safe treatment with a very low recurrence rate. You do get problems of radiation retinopathy afterwards, depending on where the tumor is, but this is our favorite treatment for these type of tumors at the posterior pole or tumors that are too large for ruthenium plaque radiotherapy. Finally, enucleation. Unfortunately, there's not much of an advance really since the really golden eye was found 5,000 years ago. It's probably the first operation eye doctors ever did was to remove the eye. And usually we do have a good outcome, but you can see mainly by the lid. The lids are usually closer together or further apart, and by the movement of the eye. So unfortunately, I cannot tell you that there is much more of an advance in recent years. The mobility and the lids are still a problem, but in most cases, I think the cosmetic result at least is acceptable. Finally, what we do in Liverpool is something special that Professor D'Amato has been setting up was the Transclear resection. That's a surgical method for large tumors that are too large for radiotherapy and the eyes that would have to be enucleated. This is really, really difficult surgery, and we keep it going basically because he taught us this method there. This is only for tumors that are too large and where otherwise enucleation would be indicated. And so this is what we try to keep on going, hopefully with success in the future. And you can remove the tumor surgically to the outside or the inside, where you go inside the eye and remove the tumor inside the eye. And this is what mainly Karl Grunwald, my consultant colleague, does. And again, you do have some good outcomes. This patient would have been at risk of losing sight from proton beam radiotherapy because it's close to the optic disc. But after the surgery, it's not for everybody, but in some very few tumors, it's a very good indication. Finally, experimental treatments. Some of you might have heard from transpapillary thermotherapy. It's a type of laser, but slow cooking laser. If you do laser, you can only treat the 1 millimeter surface of the tumor. You don't get any deeper. And if you use slow cooking laser, you can get into the deeper layers. This was really a hype about 10 years ago, treating small tumors. But as it turned out, unfortunately, these tumors have a lot higher rate of recurrence. And the recurrence comes later. So you don't see the recurrence after 6 months. You see the recurrence after 2 or 3 years. And unfortunately, then it makes it a lot more harder. So nobody does this anymore. So this is really history. We don't treat TTT anymore. An experimental treatment that is similar is photodynamic therapy. That's like a cold laser, we call it. That's been a treatment for age-related macular degeneration up until 5 years ago. And this uses a drug that will fill the tumor. You use a laser to activate that drug. It reacts to light and then clogs up blood vessels. And we do have success in some cases, but it's not for everybody. Again, it's got a higher recurrence rate. It's only for patients where we have small tumors near the point of best vision or near the optic disc, and where any other method would kill your vision, basically. So then if you say, oh, I give it a go, I want to keep my vision, it's an only eye situation, then we can try these, and they're successful sometimes. Just to finish off, just for your information, we not only see patients with choroidal melanomas, but if you visit Liverpool, you may have other patients sitting with you or next to you if you have a chat. So what do we see? Choroidal metastasis on paper should be the most common intraocular tumor, but they usually occur in patients at the end stage of the disease. We have metastatic disease everywhere. So this is why, although they should be the most common intraocular tumor, we see them perhaps 1 metastasis per 1 melanoma patient. So in clinic, they are really rare. Choroidal hemangioma, I'm sorry for the dark pictures, is the most common benign intraocular lesion. We don't have to treat all of them. We treat them with PDT, but this is what we see from benign tumors. Another benign tumor is a vasoproliferative retinal tumor. This is a benign tumor of the retina. That's a reaction of fibrotic tumor that we treat like a melanoma with a plaque usually. Finally, the conjunctival melanoma. There's another melanoma on the outside of the eye. It's completely different to a choroidal melanoma. They can be very small sometimes. This indeed is a melanoma. This is obvious that it's a melanoma. They're treating completely in a different way and just have the same name. And there are very few patients in general. So I don't know whether they're connected to OcuMel at all or whether you look at it in the future. But it may be interesting to have this small group of patients because unfortunately they also have a metastasis rate of about 20 to 30%. So it is a very, very serious disease. And finally, this is not a tumor, the cancerous growth, a benign tumor in inverted commas, but it's associated with other cancers. That's the von Hippel-Lindau syndrome. So if you want to get in touch with other patients group, there's a very strong and active von Hippel-Lindau society or patients supporting group. We do see them. These are patients that have angiomas everywhere in the body. They can develop other malignant tumors of the kidney and the pancreas and somewhere else, but in the eye we treat them for these massive vascular tumors. There's really a horrible disease, and there's a big patient group. So if you want to get in touch with them, although it's not cancer of the eye, it's somehow linked. And as I said, you probably can learn a lot from them because they have a very, very active support group going in England. So I'd like to thank you for inviting me, and I'm happy to have any questions. Thank you.
Hello. Well, thanks very much, Professor Heimann. One question, it's about the biopsies that you mentioned. And you, looking at the charts that you put forward, suggests that you've been carrying out a bit more, like I think you said a third of patients are biopsied. Is there any evidence about the risks of what tumour seeding, as it's been called, and how does that risk affect your decision-making about biopsies?
Yeah. I should repeat the question for the video. So the question is about the risks of biopsy and the risk of seeding of the biopsy. Unfortunately, I could see that I was running a bit out of time, so I can do what you shouldn't do, but quickly show the pictures. So we indeed looked at two studies. We've made ourselves to check on that. One is just the success and complications, and then we looked at all the biopsy patients and see how many had surgeries afterwards. And just to briefly go through it, the risk about seeding, is we had 2 cases in 670. So this was one of them, and we had another case as well. Fortunately, both of them were well controlled locally with treatment, but there is a risk of seeding, definitely. So we do have, this is the largest series of biopsies worldwide, 672 cases. So it's less than 1%, but it's not zero. This is what we have to tell every patient. We take every precaution about it. Are there other risks? There are. You have quite a few reoperations. Those of you who had a biopsy will know that you always get a bit of a hemorrhage, so some floaters floating around. You do have a risk of a retinal detachment afterwards. These are all the patients we had to do surgery on. About 5% of patients will have additional surgery after the biopsy. The biggest risk we have in our daily life is not getting a result, because the worst outcome would be that you do a biopsy, you cause a complication, a hemorrhage or a retinal detachment, and a week afterwards you have to tell the patient, look, we have to take you to theater again, and by the way, there was no outcome of the biopsy, which is most disappointing for everybody. And this has been a thorn in our flesh for the last years, and we're now at about 10%, lowered it to 10%. So 90% we're successful, 10% we don't get a result because we push the limits further and further. We're now down to 1.5 millimeter thickness, where we say it doesn't make sense if it's smaller than that to do a biopsy, but anything larger than 1.5, we give it a go. 9 out of 10 we get a result, but 1 out of 10 we don't get a result. And obviously my job is trying to improve the technique, or Sarah's job trying to catch the few cells that must be in there. We had it quite often that I said there's bucket loads of it, and she said not a single cell. So we have to improve that, but that's the risk, and that's the biggest disappointment we have.
Thank you. So I just wanted to ask you about the frequency again. So out of the 300 new melanomas you see, you enucleate 100?
Yes, about 100,
and
yes.
Biopsy 100?
Yes,
120.
so yes, yeah. Either the patients we don't biopsy, the ones that are thought to be too small, okay, or the patients doesn't want the biopsy, okay, where we tell them there are patients that are, say, look, it's a straightforward treatment, and we go through with everybody through the risks, the potential risks. We say there's a 0.5% risk of spread and all, and some patients decide, no, I don't want a biopsy, which is their choice, obviously. We don't try to talk anybody into it. We just offer it. Most patients do want it, but it's not that it's not forced on you. We really tell everybody, these are the risks. Do you want one, yes or no? And a lot of patients think about it. So we don't make the decision straight away. You do have some time until the treatment is there. For instance, after proton beam, we do it at the end of the proton beam. So that gives you 4 or 5 weeks to think about it. And we can also do the biopsy at a later stage. So if you had treatment and you don't feel happy about the situation, about 3 or 4 months later, we can still do a biopsy.
Thank you, Professor. You showed a picture of 4 pictures of congenital melanoma on the end.
Yeah.
For different types. One of them was a very subtle looking lesion. Can you tell us how you can suspect it's a melanoma? Is it a clinical suspicion or is it after biopsy?
Yeah.
The first one.
Yeah. The question is how tips and tricks of how to diagnose a melanoma of the conjunctiva clinically. I can't. Okay. In this case, okay, this is pretty obviously. In this one, you still can't. At the caruncle, it could, in 99 out of 100, it's a nevus. Okay. And it's quite difficult. In this one, you think that's nothing. One sign definitely is documented growth, and I can't put enough emphasis on, you need a photo documentation for it. Okay? And this one came out of nothing. So this person, very intelligent person, said, it wasn't there 2 years ago. I now can see it. So it must have grown new. So what we then do is we can either observe it or we can remove it. Observation has the problem that you have to come every 6 months, you have to wait a long time and nothing happens. And with excision, you know what it is. In this one, to be honest, I really didn't want to remove it because it was a private patient. And I thought everybody was thinking, just do it to put money in my pocket. And it was a melanoma, so small. So the only way to really find out is an excisional biopsy. And that changed completely over the past years. So we're very, in inverted commas, aggressive to remove these lesions because you can remove them in toto. If you watch them, a lot of patients will not turn up for your follow-up. And then you get a situation, this patient was exactly one like that, where it's been picked up 2 years before, small lesion like this, never follow-up, DNA, whatever, didn't happen, and then turned up with that lesion. So we changed completely over the past years in these lesions.
Regarding indeterminate lesions that you mentioned,
yeah?
Can I quickly ask you, if you have lesions on ultrasound more than 2 millimeters with autofluorescence showing orange pigment and subretinal fluid on OCT, how do you finally make that decision clinically that is indeterminate and then you tend to follow them up? Because this is relevant when we refer patients on with these findings. And then obviously, as an oncologist, you do make that decision. But is there anything that we can sort of clinically say, other than obviously the size and the thickness, that you would sort of go for to say that it's indeterminate and not melanoma?
I think in these lesions, really the ultrasound comes into play. So if it turns into a melanoma, in most cases, you do have a low internal acoustic reflectivity on ultrasound, and you can pick these lesions up on ultrasound. Whereas in most cases of nevi, you don't really see that. So size does matter. The most important part is documented growth, again. So if you have 1 or 2 risk factors like orange pigment and fluid, but it's not a big lesion, then the most important thing is to take a very good photograph and look at that photograph 6 months later. So then we really look for documented growth. If it's a larger lesion, we would go for a biopsy or offer that at least to the patient.
So if you don't have...
Can I just say that this afternoon we're going to have time with, you're going to have time with Professor Heimann, so you can maybe go into a bit more detail.
Okay, thank you very much, Professor.
Okay, thank you.